Hello everyone, my name is Jen Nolan and I'd like to welcome you to the second webinar in Move Muscle, Bone and Joint Health 2018 Musculoskeletal Health webinar series. Tonight's webinar is on the diagnosis and management of axial spondyloarthritis. Move Muscle, Bone and Joint Health has some great webinars in the first half of the year and the list should be on your screens now. You can purchase the webinars individually or as a series, and the recordings of previous webinars are also available for purchase at any time. Our presenter for this evening will be Dr. Lionel Schackner. Dr. Schackner runs the Austin Spondylitis Clinic in Melbourne. After completing rheumatology training at the Alfred Hospital and Monash Health, he completed a postdoctoral fellowship and PhD in clinical investigation at Johns Hopkins University in Baltimore. His research interests include epidemiological studies in predictors of outcomes in axial spondyloarthritis. Without further ado, I'll hand proceedings over to Dr. Schackner, who will present this evening. Thanks very much, Lionel.
Thanks, Jen. Thank you very much for joining me tonight in a discussion on the diagnosis and management of axial spondyloarthritis. We're just going to talk about some basic principles, which I hope you'll find helpful in your daily practice. So this is the agenda. We'll cover three topics. Firstly, we'll look at the diagnosis of axial spondyloarthritis and focus on the two main subtypes, that of non-radiographic axial spondyloarthritis and the well-known disorder ankylosing spondylitis. We'll then talk about screening for suspected axial spondyloarthritis in primary practice. And finally, we'll touch on some of the principles with regards to treatment of axial spondyloarthritis. So first, the diagnosis. One point I want to make first is that this is a picture of the typical patient with ankylosing spondylitis, really in a historical era. Very rarely do we see individuals these days who develop such severe kyphosis that they're greatly disabled by it. This change came about even prior to the availability of the TNF inhibitors in the late 1990s. It was probably in the 70s and 80s that things changed around when we recognized the importance of regular exercise and NSAIDs, the nonsteroidal anti-inflammatory drugs, may have also played some role here. Firstly, in terms of spondyloarthritis in general, there are a number of spondyloarthritides, and they're listed here, ankylosing spondylitis being the main one. The reason why these conditions are come under the term spondyloarthritis is that they share a number of features. They share the features of inflammatory back pain. They have a unique type of peripheral arthritis, specifically oligoarthritis of large joints, particularly of the lower limbs. Enthesitis is a key feature, and dactylitis is seen in variable frequency according to the disorder. They're all associated with extra-articular features, including iritis, psoriasis rash, and bowel lesions. They all can be associated with imaging changes at the sacroiliac joints and spine, and they also share genetic features. What I want to just highlight here is that it's useful to differentiate or break up the spondyloarthritides into two groups. One group being the axial spondyloarthritis, which is AS and non-radiographic axial SPA, and the peripheral group, which predominantly is psoriatic arthritis, reactive arthritis, and arthritis of inflammatory bowel disease. We certainly recognize that there's an overlap, meaning that patients with AS, for example, can have peripheral arthritis. That occurs in up to 50% of patients. And certainly patients with psoriatic arthritis, for example, can have spinal involvement as well. but this is a very practical way of dividing up the spondyloarthritis into axial and peripheral. The reason why it's useful is in terms of treatment approaches. Conventional DMARDs, such as methotrexate and sulfasalazine, are only effective for peripheral spondyloarthritis and really are not used for spinal disease at all. Physical approaches are effective for axial spondyloarthritis, and we're going to focus on axial spondyloarthritis. Exercise is a key feature in terms of key element of its treatment. The symptoms and signs differ according to axial versus peripheral spondyloarthritis, and the outcome measures of note also differ, and we'll talk a bit about this. So with regards to axial spondyloarthritis, it's a form of chronic arthritis of the spine characterized by inflammatory back pain. We've spoken about the two classifications. The prevalence estimates, chronic low back pain is very common, ankylosing spondylitis certainly less so, and a key part of assessing these patients in primary practice is trying to work out which patients are likely to have ankylosing spondylitis or axial spondyloarthritis. So approximately 1 in 200 individuals in the community have ankylosing spondylitis, and axial spondyloarthritis is 2 to 3 times that frequency. In order for us to differentiate between ankylosing spondylitis and non-radiographic axial spondyloarthritis, we really need to have a look at an X-ray of the sacroiliac joint. The sacroiliac joints can usually be seen on a single AP film of the pelvis. One doesn't need to ask for dedicated sacroiliac joint X-rays, and in fact that increases the amount of radiation that the patient receives. The true synovial joint is the anteroinferior half, and this projects over the lower third of the X-ray film, and this is the area where we want to mainly focus. So this is a normal film sacroiliac joint. We know it's normal because we can see clear cortical margins here, and also the joints are symmetric and uniform throughout. So if we can see clear cortical margins and uniform joint width, we know we're dealing with a normal sacroiliac joint. Just a little bit about the gradings of the sacroiliac joints on X-ray. The key findings are really those of repair after inflammation. So they include sclerosis, erosions, and ankylosis. These are the gradings. 0 is normal. Grade 1 is suspicious sacroiliitis with possible changes. Grade 2, early changes of minor sclerosis, limited erosions, and joint space narrowing. Grade 3 is when there's definite sacroiliitis and those changes are more prominent. And advanced sacroiliitis is ankylosis or fusion. So here we just run through the grading system. This is grade 1 where we've lost the cortical margin, but the joint otherwise looks okay. So I would call this grade 1 or suspicious changes. In grade 2, we're seeing fairly prominent sclerosis. We've certainly lost the cortical margin completely. So grade 2 is definite changes. Grade 3 are the advanced changes where there's a significantly greater amount of sclerosis. There's prominent erosions and so-called pseudo-widening of the joint. And grade 4 is when there's total fusion or ankylosis. Now, in order for us to actually make a diagnosis of ankylosing spondylitis, we need to have at least grade 2 bilaterally or grade 3 to 4 unilaterally of the X-ray changes. So if we don't have those X-ray changes, we can't make a diagnosis of ankylosing spondylitis. And then we need at least one of the clinical criteria, which include low back pain and stiffness for more than 3 months, improves with exercise but not relieved by rest, limitation of motion of lumbar spine, both sagittal and frontal planes, and also limitation of chest expansion. So if you've got the radiological criterion and at least one of the clinical criteria, then we can make the diagnosis of ankylosing spondylitis. Part of the problem is that it often takes 10 years or more after the onset of symptoms for the X-rays to become abnormal. So again, we need bilateral grade 2 changes, and if the changes are unilateral, they need to be at least grade 3. So the question is, if it takes 10 years or more for the X-rays to become abnormal, how do we define the patients before they develop X-ray changes? And here the concept of axial spondyloarthritis is important. We recognize that there's a non-radiographic stage and there's a radiographic stage. The non-radiographic stage will precede the radiographic stage, usually by a number of years. So initially the patient presents with back pain. We'll talk about MRI shortly. They may or may not have sacroiliitis on MRI. And then at some stage down the track, for those who are going to develop ankylosing spondylitis, radiographic changes appear at the sacroiliac joint, and even further down the track, syndesmophytes or bony fusion of the spine can develop. There is a classification definition for axial spondyloarthritis, and it's here in this slide. It's important to recognize that these classification criteria in rheumatology are used primarily for research purposes in order to get homogeneous populations to study, but they still are useful to help us understand concepts and definitions of disorders. So for this classification criteria for axial spondyloarthritis, the patient needs to have back pain for at least 3 months and the age of onset of the back pain before the age of 45 years. Then they need sacroiliitis on imaging, and that can be either X-ray or MRI, plus at least one of the spondyloarthritis or SPA features, which includes inflammatory back pain and a number of the features which I mentioned early on that are unique to the spondyloarthritis group. Now, because we know at least 20% of patients will have normal MRIs, there's another part of the criteria where if the patient's got HLA-B27, they need to have at least 2 of these features in order to satisfy the criteria. It's recognized that sacroiliitis, either on MRI or X-ray, and at least one clinical feature is more specific for the diagnosis of axial spondyloarthritis. How quickly do patients progress? What's the proportion? So this slide tells us the approximate rates of progression. So from non-radiographic axial spondyloarthritis, approximately 60% will progress to radiographic disease within 10 years. And then approximately 25% will progress to complete spinal fusion within 30 to 40 years. Important to recognize that this 25% figure is based on very old data, and I suspect that it's significantly less today. It's important to recognize that non-radiographic axial SPA can be associated with significant morbidity even though the patients don't yet have X-ray abnormalities. So, for example, BASDI, which is a disease activity index, is actually fairly much the same, but with among AS and non-radiographic spondyloarthritis patients. The main way that patients with AS are significantly worse are in terms of day-to-day functioning. So this is a measure of function where the scores are higher for AS compared to non-radiographic spondyloarthritis. Just very briefly about syndesmophytes. Syndesmophytes develop from vertebral corners. The vertebral corner is an enthesitis point where the annulus fibrosus of the intervertebral disc inserts. And that's a site where bony changes first appear on X-ray, either erosions or sclerosis, so-called shiny corners, and these are the sites where syndesmophytes will develop from. So just looking at some X-rays here, this is a shiny corner where there's some sclerosis, there's an erosion here, and the syndesmophyte is taking off from this area, and syndesmophytes develop from the vertebral corners. There are various grading systems. This is the most common one that we use. The reason why I put this up is to just demonstrate that the best way of actually assessing the amount of spinal fusion is by looking at the vertebral corners and seeing whether there are so-called, they're normal or so-called grade 1 changes, or grade 2 or grade 3 where there's bridging syndesmophytes. In this scoring system, only the cervical and lumbar spine are scored because the thoracic spine is difficult to view adequately because of overlying lung and bowel gas. This figure is really just simply to illustrate that a measure of disease activity called the ASDAS correlates with radiographic damage and progressive fusion over time. So this figure would suggest that if we can control inflammatory activity, we have a good chance in slowing down spinal fusion over time. There are a number of predictors of radiographic progression at the sacroiliac joint and the spine. The baseline level of radiographic damage is a key predictor. Certain measures of inflammation on MRI and blood tests are also predictors. Smoking is a key one that we all have a responsibility to address when we're seeing patients with ankylosing spondylitis. Okay, so now we'll move on to screening for axial SPA in patients with chronic back pain. Up to 5% of patients presenting to the general practitioner with chronic back pain will have either ankylosing spondylitis or non-radiographic axial SPA. The major challenge in general practice is to identify these patients from among the large population of chronic back pain. Some additional difficulties in identifying these patients is that objective measures of spine mobility are typically normal for several years after the onset of symptoms. And as we mentioned before, the X-rays are often normal for 10 years or more after onset of symptoms. Facing all of this, it's important for early referral of suspected cases. Just very briefly on inflammatory back pain, the Callan criteria from 1977 are the ones that we're all familiar with. The onset before the age of 40, duration of back pain longer than 3 months, insidious onset of symptoms, morning stiffness lasting more than 45 minutes, and improvement with exercise. I just want to highlight a couple of other features that have been recognized to be fairly specific for inflammatory back pain, and those are awakening in the second half of the night because of pain. Patient goes off to bed quite comfortably, and then throughout the night, lying in the one position, they stiffen up and may awake, say, at 2 or 3 o'clock in the morning with spinal stiffness. And the other feature that's fairly specific for inflammatory back pain is alternating buttock pain. One day the pain's on the right side, and then the next day it's on the left side, and it may stay in one side for a week or two, then move to the other side. But that's also a fairly specific feature of inflammatory back pain. Just want to show you this measure called BASDI. It stands for the Bath in the UK, where it was developed, ankylosing spondylitis disease activity index. And there are 6 visual analog scales. The patient puts a mark as to where they think they've been over the last week. So the first question relates to fatigue. So if they've been very tired, they might put a mark up here. Next question relates to neck, back, or hip pain. The next one's about pain and swelling in peripheral joints. The next question's about overall level of discomfort to any areas tended to touch or pressure. And this gets to enthesitis. And then there are 2 measures regarding morning stiffness. One is how severe, and the next is the duration. In order to score the BASDI, you take the average of number 5 and 6, and then add that to the other scores, and then divide by 5. So essentially it's the mean score, and these lines are 10 centimetres in length, and a score above 4 is generally considered to indicate active inflammatory back pain. I just want to quickly run through spinal mobility measures. The one that's most commonly known is the modified Schober's test. There are a number of ways of doing this. Probably the easiest is to just put a mark first at the PSIS or at the dimples of Venus, another mark 10 centimetres above, and then you ask the patient to keep their knees straight and try to bend forward and touch their toes as best as they can. This distance should increase from 10 up to at least 15 centimetres. Then there's the occipital distance and the tragus to wall distance. So the occipital distance is the one that's probably the easiest to measure. The reason why some people like the tragus to wall distance is that it doesn't matter as to where one holds your chin. You can lift your chin up or down. The tragus to wall distance stays the same, while when you measure the occipital distance, the head has to be held horizontally. Lateral spinal flexion is actually the most useful measure, and if you're going to do one measure in your practice, it would be lateral spinal flexion. So the patient stands up straight, heels and bottom up against the wall. You measure the distance from the tip of the middle finger to the floor. The patient is then instructed to reach down their leg as far as they can while keeping their back up against the wall, and the distance is remeasured. And you look at the distance, the differences between the two, and it should be 10 centimetres or more. And then chest expansion at the level of the 4th intercostal space, or at the level of the nipples. Get the patient to take a big breath in, out all the way, and another big breath in, and measure the difference between maximal inspiration and expiration in centimetres. It should be at least 5 centimetres. A key point that I want to make is that in order to identify patients with axial SPA early on, history is key. And so the sort of things you'd be asking the patient, you get a sense of how old they were when their symptoms came on. Are their symptoms ongoing? What happens with exercise and rest? Symptoms ongoing. What happens with exercise and rest? Is there a sleep affected? Is there a family history of SPA? And do they have other features such as psoriasis, uveitis, or colitis? This algorithm was published several years ago now, but is a good way to think about our approach to getting to the diagnosis of axial spondyloarthritis. So for the individual patient out there in the community with chronic low back pain, there's a 5% probability that they'll have axial SPA. If they have inflammatory back pain, that probability only goes up to 14%. So one often thinks that if you have inflammatory back pain, then you have got spondyloarthritis, but that's actually not the case. One needs to look for other SPA features, which are listed here, including heel pain, dactylitis, and uveitis. If there are at least 3 of these features, then we can be 80 to 95% confident that we've identified the patient with axial spondyloarthritis. If they have 1 to 2 features, then it's recommended that to do HLA-B27, and then if that's positive, then you can be fairly certain you're dealing with axial spondyloarthritis. If B27 is negative, then by this algorithm, one should consider other diagnoses. If you have inflammatory back pain but no SPA features, then you check the HLA-B27. If that's negative, consider other diagnoses. If that's positive, then an MRI would be useful here. As we mentioned before, if the X-ray changes are present at the sacroiliac joints, then we've identified the patient as having ankylosing spondylitis. There have been a number of studies that have looked at which patients should be referred to a rheumatologist. And the consensus is that if there's a patient who's had back pain for at least 3 months and 1 or more of the following, then they should be referred a positive test for HLA-B27, inflammatory back pain, or sacroiliitis on imaging. I just want to run through 4 misconceptions about axial spondyloarthritis that may limit or make one think that a patient doesn't need to see a rheumatologist. The first misconception, patients with normal inflammatory markers cannot have ankylosing spondylitis or SPA. Second one, a normal X-ray result of sacroiliac joint excludes the diagnosis. The third, patients who test negative for HLA-B27 cannot have ankylosing spondylitis or spondyloarthritis. And 4, women are unlikely to have axial spondyloarthritis or ankylosing spondylitis. So the first misconception, inflammatory markers can be normal in patients with active axial SPA. We know that ESR and or CRP are elevated in only 50% of patients with active SPA. The inflammatory markers are more likely to be elevated if there's an associated peripheral arthritis or inflammatory bowel disease. And in a patient who has elevated CRP, it is a predictor of radiographic progression. The second common misconception, patients with a normal X-ray can have early disease. This is the actual fact that we've actually spoken about this already, so I won't discuss this other than mentioning that early inflammatory changes may be detectable on MRI before the X-ray becomes abnormal. patients who test negative for HLA-B27 can have ankylosing spondylitis. So while B27 is strongly associated with the likelihood of developing a spondyloarthritis, about 10% of patients with ankylosing spondylitis test negative for HLA-B27. So HLA-B27 is just a normal genetic variant, occurs in approximately 8% of Caucasians, but only 1 to 5% of HLA-B27 positive individuals will develop ankylosing spondylitis. If symptoms support a spondyloarthritis diagnosis, these patients should be referred to a rheumatologist regardless of their HLA-B27 status. And finally, women are as likely as men to have early axial spondyloarthritis, but less likely than men to have ankylosing spondylitis. Early axial spondyloarthritis affects men and women equally. Not everyone with axial spondyloarthritis will progress to ankylosing spondylitis, but among patients with ankylosing spondylitis, about 30%, a non-insignificant proportion, are women. The delay in diagnosis is longer among women than men, mainly because the diagnosis is not considered in women, and also spinal mobility is generally preserved for a longer period of time. Just very briefly, MRI in axial spondyloarthritis, there are two sequences that we're interested in. One is the STIR sequence, where we can see acute inflammation, and we're looking for marrow edema or osteitis. That allows us to assess active sacroiliitis. And the other sequence is a T1 weighted sequence, where we can see the same changes that we see on X-ray, sclerosis, erosions, and ankylosis. But we can also see post-inflammatory fatty change that occurs, thought to occur perhaps between inflammation and the development of bony fusion. So this is an MRI STIR sequence. We know it's a STIR sequence because the disc has lit up, and there's increased signal around the sacroiliac joints. This shows that the MRI changes, these are STIR sequences, actually resolve with treatment, effective treatments, etanercept, one of the TNF blockers. This again is a STIR sequence showing active inflammation. This is a T1 sequence, and where there's increased signal, it's not indicating inflammation, but post-inflammatory fatty change. And we can also see changes at the vertebral corners. So we can see here on the STIR sequence increased signal at a vertebral corner, and it's dark on the T1 weighted image. This is an X-ray showing a syndesmophyte, and then alongside that, there's increased signal at the vertebral corners indicating that there's active inflammation. For the rest of the presentation, I'll talk about treatment approaches in axial spondyloarthritis. The management of axial spondyloarthritis involves a multidisciplinary team facilitated by the rheumatologist. The goals of treatment are to reduce inflammatory activity with effective treatment, improve and maintain spinal flexibility and function, prevent progression of structural damage, support social participation, and support long-term health-related quality of life. Optimal disease management combines pharmacological and non-pharmacological treatments. So first-line treatment is a combination of nonsteroidal anti-inflammatory drugs and physiotherapy. There's no preferred nonsteroidal. They can be used continuously if there's active inflammation, as long as one is tolerating these medications. And we would generally define a non-responder as a patient who doesn't respond to 2 or more NSAIDs over a 3-month period. With regards to systemic glucocorticoids, we will sometimes consider that, but usually doesn't have a role to play. If there's active AS despite NSAIDs and exercise, then we tend to move on to the TNF inhibitors. There's no preferred agent. If the patient has recurrent iritis, we tend to favour infliximab or adalimumab, for which there is the best data available. For those who have inflammatory bowel disease, all the TNF inhibitors work aside from etanercept. And we now have availability of an IL-17 inhibitor as an alternative to the TNF inhibitors. With regards to exercise, a supervised exercise program or individualized home-based exercise is better than no exercise at all. But if you have a choice, a supervised group physiotherapy session is better than home exercise. Combined inpatient SPA exercise followed by group physio is better than group physiotherapy alone. With regards to NSAIDs, NSAIDs probably have no disease-modifying effect, although some studies have demonstrated it to have effects on slowing radiographic progression. NSAIDs should be used for symptom modification only. And then one needs to decide whether it's safe to use continuous or on-demand treatment. If the condition is inactive on a TNF inhibitor, NSAID continuation is not warranted. This figure shows the available TNF inhibitors. Infliximab, which is a chimeric monoclonal antibody with murine and humanized components, human monoclonal antibody, adalimumab and golimumab, a recombinant receptor fusion protein, etanercept, and then there's the FAB fragment of immunoglobulin, certolizumab. The TNF response rates are fairly equal across studies, even though there haven't been any head-to-head comparisons between TNF inhibitors. An ASAS 40 response is actually a very good response. So we're seeing that up to 50% of patients have a very good response to TNF inhibitors. I would say that in 85 to 90% of patients, it's quite a noticeable response as far as the patient is concerned. The TNF inhibitors don't tend to wear off over time. Sometimes we do need to switch agents, but for the majority of patients, they can continue on with their first TNF inhibitor long term. There are major improvements in disease activity. All of the extra-articular manifestations respond to the TNF inhibitors. The main notable exception is that of inflammatory bowel disease and etanercept. Measures of spinal mobility almost always improve, functional ability and quality of life. Patients tend to need to continue TNF inhibitors long term, and if they do come off the TNF inhibitor, there tends to be a recurrence of symptoms within 3 to 12 months. Patients who have short symptom duration, elevated CRP and active MRI inflammation are more likely to have a better TNF response. We can see that TNF inhibitors have also been studied in non-radiographic axial spondyloarthritis. The response rates are just somewhat higher compared to patients with established ankylosing spondylitis. The unfortunate thing in Australia is that the current PBS criteria are for ankylosing spondylitis only, meaning that there needs to be radiographic changes at the sacroiliac joints. Just a little bit about the safety concerns of TNF inhibitors, infection being the main one. If one has a serious infection, it's best to withhold the TNF inhibitor for a period of time. With regards to TB, all patients are screened for TB prior to commencing treatment. If latent TB is identified, we tend to start treatment with isoniazid, and then once it's established that they're having no side effects, then we move on to the TNF inhibitor. Hepatitis B is also an infection that we screen for prior to commencing treatment. Lymphoma and other cancers may be higher in patients receiving TNF inhibitors. We have seen more reassuring data in recent years that the risk of malignancy may actually not be greater. And neurologic disorders, very rarely there can be an association with the myelinating disorders, certainly in a patient with a past history of multiple sclerosis. We will avoid the use of a TNF inhibitor. Just some important treatment guidelines. As I mentioned before, discontinue treatment in the presence of serious infection. Live attenuated vaccines such as shingles vaccine, yellow fever, and oral typhoid cannot be administered to a patient on a TNF inhibitor or, for that matter, any biologic. Patient needs to be aware of increased risk of skin cancer and the importance of preventative care and surveillance. If a patient does need surgery, we tend to withhold the TNF inhibitor for one treatment cycle. So, for example, with adalimumab, which is administered once a fortnight, we would withhold treatment for 2 weeks before surgery. And then generally, 1 week after surgery, the TNF inhibitor can be recommenced as long as there's no concern about healing or infection. With regards to radiographic progression over time, short-term treatments with TNF inhibitors do not appear to impact upon radiographic progression. There are a number of studies that had a look at various TNF inhibitors and compared them to historical controls, and there was no slowing of radiographic progression. However, more recently, there have been more longer-term studies that do demonstrate that TNF inhibitors do slow radiographic progression over time. It appears that if one is on a TNF inhibitor for 4 years or more, then there is slowing of syndesmophyte formation and fusion of the spine. This is from a recent study that had a look at factors that were associated with radiographic progression. The factors that are here on the right-hand side that don't cross 1, such as male sex, that's associated with increased progression, and really the only factor here that was shown to be associated with slowing of radiographic progression was TNF inhibitor use prior to that X-ray measure. The current PBS criteria for initiation of treatment: you need to have the X-ray changes, bilateral grade 2 or unilateral grade 3 sacroiliitis, at least 2 of the following. So basically, these are the modified New York criteria for ankylosing spondylitis, which I mentioned earlier on. And then you need to have had an inadequate response at least 3 months of 2 or more NSAIDs plus exercise. This is the BASDI that we'd had a look at before. The BASDI score needs to be 4 or above. And then we reassess patients at the 4 to 5 month mark, and if their BASDI score has decreased and the inflammatory markers have come down, then we can continue on with treatment. We know that a proportion of patients don't respond to TNF inhibitors. In that situation, we can either add methotrexate, we can switch a TNF inhibitor, use a biosimilar, or switch to an IL-17 inhibitor, secukinumab. There are a number of agents that are effective but not PBS listed, And we also recognise that some of the biologics that we use in rheumatoid arthritis are not effective in ankylosing spondylitis, and they're listed here. This slide just demonstrates the efficacy of secukinumab, the IL-17 inhibitor. It's effective both for TNF-naive patients, those who've never been exposed to TNF inhibitor, and also effective, somewhat less so, for those who've previously been on a TNF inhibitor. So, in summary, with regards to treatment, treatment for active AS typically begins with exercise and nonsteroidal anti-inflammatory drugs. If after that one still has active disease, we think about moving on to a TNF inhibitor or the IL-17 inhibitor. TNF inhibitors are most effective if started less than 10 years after the onset of symptoms, so therefore early diagnosis is essential. And then there are a number of things that patients need to be monitored for if they're on a TNF inhibitor, and there are a number of other other agents where studies have shown that they have some likelihood of improvement in symptoms, and they may be available to us sometime in the future. The role of the GP post-referral, I think, is to promote patient education, self-management, including self-help groups, encourage physiotherapy and daily exercise, importantly to discourage cigarette smoking, to encourage treatment adherence, because the temptation is that patients feel better and they may decide they want to come off treatment, recognizing the side effects of treatment and working together with your rheumatologist in how best to address it in the individual patients, and then to perhaps identify when additional therapy or change in therapy is needed, and to get in touch with your rheumatologist. So I thank you for your attention, and I'm happy to take any questions.
Well, thank you, Lionel, for an incredibly clear and comprehensive presentation. You just covered all aspects so thoroughly. That was fantastic. But I encourage people to type in questions if you have any. I must say, you know, the presentation covered so many aspects that there wasn't left a lot to be left to be sort of wanting to know and so on. One query I just had, Lionel, was in relation to the obviously the age of onset is very critical in taking that initial history and so on. What is the sort of the thinking behind the fact that it has that particular age focus with regards to the onset of these conditions?
Well, I'm not sure that we truly understand why it comes on at a young age. It tends to occur between the age of 15 and 45 years. But I think we're fortunate that that's the case because most mechanical back pain comes on over the age of 50 years. So we can use that aspect to actually help us identify patients who are at risk of having axial spondyloarthritis. I think that's a very important factor to take into mind. Keep in mind. It's also very important that even if the patient presents later in life, that you take a good history and try to perhaps identify clues that perhaps they had inflammatory back pain earlier in life, but they just had inflammatory back pain earlier in life, but they just have forgotten about it.
That there is also a juvenile spondyloarthritis with the management of children that would be undertaken by a paediatric rheumatologist with a similar sort of approach with regards to the pharmacologic and also non-pharmacological management?
Yes, it generally is. Children are a little bit different in their presentation. Often they'll have involvement of the feet. They get so-called tarsitis, where the feet become very swollen. If that's the case, they'll respond better to the conventional disease-modifying drugs such as methotrexate or sulfasalazine. But, certainly later on, as they get older, the presentation tends to be more typical of what we're used to seeing in adults.
And is there, with regards to current sort of the focus of current research in the area, is there anything of particular interest and note that would be worth mentioning?
Yes, certainly. There's a lot of research in various aspects of the disease. There's certainly a lot of research into the microbiome and its relationship to the pathogenesis and development of the disorder. Spondyloarthritis is one of the key disorders that the microbiome is thought to be very important in terms of early pathogenic mechanisms. There are new agents being studied in various spondyloarthritis, particularly in psoriatic arthritis, which is a subtype of spondyloarthritis. There are a number of new drugs that are in development, and some of them are also being studied in spondyloarthritis.
Okay, it looks like we don't have any questions forthcoming, which, as I say, I'm not surprised because it was such a comprehensive and clear presentation. Lionel, I'd like to thank you very sincerely for the amazing amount of work you put into that presentation and for your wonderful, clear sort of presentation this evening. I'd like to thank you very much. I'd also like to thank people who joined the webinar this evening, and I'd also ask that you take a moment to complete the exit survey. And I'll also remind you of our next webinar, which will be screening on Thursday, the 26th of April, and it will be about better understanding painful tendons. And we have Professor Bill Vincenzino from the University of Queensland presenting that webinar. So we're finishing a few minutes early, but with no further questions forthcoming, I'd like to thank you once again, Lionel, and thank everyone else this evening, and wish you all a good night. Thank you.
Thank you.